Hi, thank you all for joining us here today for this presentation on lower back pain by Dr. Colin Gundling of Alliance Physical Therapy. Um, we'll be recording this program to post to our Facebook and YouTube pages, so it should be available there Wednesday night. If you have questions during the program, you can ask them in the chat, and Dr. Gundling can either answer them then, or we can get to them at the end during the Q&A. Or you can ask your questions then if you prefer. Yeah, with that, I'll be muting us all, so I will hand things off to Dr. Gundling.
There we go. Thanks a lot, Corey. Thanks for having me again. I know it's been a little bit of time since we last did this, so I'm excited to get in and talk about some new topics or variations on old topics. So the idea of this whole series from the beginning has been with the goal of kind of filling the gap between what people understand about healthcare and what the current healthcare model is presenting as far as our ability to be active and try to achieve things through activity and understanding the orthopedic care continuum and understanding orthopedics a little bit better. And one of the most common orthopedic issues that we see in medicine and across the country, across the world, is low back pain. So our discussion today is going to try to focus on low back pain as much as possible, and give everyone a little bit of a better understanding of what we're dealing with when we talk about low back pain. So as we go into this, just remember this: the idea of this is to empower you with some information that can help you make some decisions. Obviously, you want to talk to your doctor, physical therapist, or whomever is working with you about those decisions. But I like the idea of these discussions are designed to just empower you with a little more information than you would maybe get from Googling low back pain. So today, we're going to give you the lowdown on low back pain. Now, like I said, low back pain is super common. It's really a 90% chance of experiencing low back pain at some point in our lifetime. So the chances are at some point in your life, you're going to have some significant low back pain that's going to limit you in your ability to work throughout your day. Low back pain is the second most common reason for visiting your primary care practitioner. So that is very significant when we look at all the reasons that we might go to our primary care practitioners. And up to 25% of cases of low back pain become chronic. So if you think about 90% of us have low back pain and 25% of those cases become chronic, that's a significant portion of the population that is dealing with chronic low back pain. And the thing about chronic low back pain is it probably could have been prevented with some management early on. There are certainly cases where it is going to be chronic, but proper management early on can significantly reduce the risk of chronicity with your low back pain. Now, something else to understand about low back pain when it's acute, so when it just happens, there is a pretty typical process of pain that your body goes through. Somewhere within 6 to 8 weeks of it occurring, it will probably improve significantly. Now, how much it will improve will be based upon a lot of factors, both your predisposition for pain and issues, your activity level before and after the incident of causing the low back pain. There's a lot of factors that go into play. Some of those things you have control over, and some of those things you don't, which we'll talk more about later on in the discussion. One of the biggest things is when people come to see me initially with the complaint of low back pain, they always come to me, not always, but oftentimes they come to me talking about like the terminology, the words that were used to describe their low back pain. Things like disc bulge and spondylolisthesis and spondylosis and all of these different terms that do sound kind of scary, to be honest. And one of the things that I'd like you to take from this discussion today is that generally they have a bigger bark than bite. when we talk about these terms, because a lot of these terms that are used to describe low back pain are just degenerative changes that are happening to the spine. And if you've listened to any of the other discussions that I've given, and we'll go into further detail with this stuff when we talk about arthritis in a few weeks or in maybe a month or two, our bodies have a typical process of aging that we go through. We see that externally on our skin through wrinkles and things like that. And it happens internally. It happens to our joints. It happens to our bones. It happens to everything. So the great majority of this terminology here is really the idea of aging in our tissues. Now, some people age a little bit better than others, and some people take better care of themselves and age a little less rapidly, and other people either use the certain tissues too much or don't use them enough and age more rapidly as a result. So those are things that factor in. However, just having the diagnosis or identified something like stenosis in your back doesn't equate to symptoms. So this is important to remember. Just having something identified in your MRI does not equal symptoms. Does it increase the possibility of having symptoms? Yeah, maybe. But something that is important to remember is that it is relatively typical for us to have these findings on MRI whenever we are even non-symptomatic. So there's been some studies done on individuals that are non-symptomatic, so they have no back pain at all. And the frequency of stenosis, which is a classic term used with low back pain. Stenosis means a narrowing of the holes that the nerves come out of in the spine. That frequency of stenosis in people around age 65 is almost 70%. So it's a significant amount of the population, even without low back pain, that still has these symptoms, or that still has these imaging findings without symptoms. That's not to say that stenosis can't cause symptoms, though, because it certainly can, but it doesn't guarantee that it will. And just having stenosis, just like having arthritis or some other issues identified on imaging, it doesn't mean that once you have pain with it, the only solution is surgery to get rid of it. That's not the case. In fact, there are a lot of great treatments out there to take pressure off of these tissues and put pressure somewhere else so that you don't irritate them quite as easily. So if we go through some of these terms and just talk about them real quick, we can see stenosis is the one that I already identified. Spondylosis is a general term for degenerative changes in your spine, whereas stenosis is specific to the narrowing of the holes that the nerves come out of. Spondylolisthesis is a long, fancy word, which means basically a slipping of the vertebrae on one another. So one slips slightly forward or one slips slightly backwards, depending on your specific issues there. So that typically means there's a lack of stability in the spine that can cause some symptoms potentially, but again, not necessarily. Facet arthropathy is the facet is the joint of our spines. So a lot of times people will think the disc is the joint of our spines, but the disc is really just a cushion between the spine bones. The joints of the spines are actually a little further back and on the spines behind the discs, and that is typically. I'm going to try to pull up a picture of a spine to show you guys here, because sometimes it is a little bit easier to see that. So those joints, just like any other joints in our body, can become arthritic. So facet arthropathy is an arthritic change in the facet joint of the spine. So let's see here. Let's do this. Okay. So we could see that the spine here, we can see you have your cervical spine, thoracic spine, lumbar, and then sacral spine at the bottom. And the discs are between the vertebral body. So we have the blue vertebral bodies down there in the lumbar spine and the discs between them. If you go back from the vertebral body, there's a round kind of circular part of the bone that goes backwards, and then you have the spinous process that goes further back. That circular part is the facet joint, so it rubs up against the joint above it, and that helps the spine kind of slide and glide and twist and limits some end range movement in the spine and things like that. So it's a very valuable thing to us, but sometimes they can become arthritic. Again, if we're talking about going back to what I was discussing before about the spondylolisthesis, that basically means one of the vertebral bodies, the bone and of the vertebrae, is slid forward or backwards relative to the one above and below it, which is pretty common, and it doesn't mean your spine is falling apart. So then if we continue down our list of findings with respect to imaging, we also talk about issues with the discs. So the disc bulge or disc herniation or degenerative disc disease. So if we're talking about disc bulges, that is when the disc is pushing out slightly into other tissues around it. So we have within our discs, they're basically like jelly donuts. Okay, so they have a fibrous outside, and on the inside, it's kind of a gooey center. And sometimes if we stress that disc in different ways, that gooey center can get pushed out against the fibrous outside, and then that fibrous outside pushes out a little bit outside of where that disc typically sits. You can see here's the vertebral disc in the body right there. So the disc goes between. Again, these are supposed to be cushioning. So if we put a lot of stress on that cushioning, just like any spring, sometimes it ends up becoming injured. Now, a disc herniation is different than a disc bulge because that's actually where the disc, the jelly in the jelly donut pushes out of the fibrous band around the disc. And there are times when those disc herniations can heal, depends on where they herniate and what happens as far as subsequent treatment goes. But there is potential for healing in those cases. It's just a matter of a lot of factors. Some that, again, you have control over and some that you don't. And then the last one with respect to the discs that is pertinent that we see a lot is degenerative disc disease. So when someone has degenerative disc disease, that is basically when the jelly inside the jelly donut kind of dries up. The discs become more fibrous and less fluid filled. And one reason, I'm sure as we age, people are aware that as we age, we decrease on our height. Our height decreases. And one big reason for that is because our discs in our spine don't fill up with fluid quite as much. And we know that the discs in our spine fill up with fluid when we're not influencing them with gravity, because we're always taller in the morning than we are at night. So over the course of the day, the fluid in those discs gets kind of squished out of them, and we lay down at night and the fluid comes back into the discs, which is sometimes the reason why certain diagnoses of certain issues in the low back have more or less pain in the mornings. So the discs, however, as we get older, become less fluid filled, more fibrous. And when we image them, we identify degenerative disc disease by a darker disc is what we see. Again, this isn't something that means you need new discs put in. That's not really realistic in many cases. It just means that your discs are getting older, and it happens with the great majority of the population. And then other issues in the spine. Now, this issue is certainly a bigger issue, fractures. So if you have fractured spinal segments and vertebrae, that's something that you would need to get some medical attention for. There are different types of fractures in the spine. You could fracture the back of the vertebrae, like where the facet joints are, or the spinous processes that stick off the vertebrae, by like a blunt force trauma to the area. Another thing that could fracture, and this is common as we get older, and we're going to have a talk on osteoporosis, and we'll discuss this more in those discussions, but like a compression fracture of the vertebral bodies can occur, and that Doesn't have to be because of any blunt force trauma. Sometimes that just happens because of the bone mineral density of those vertebral bodies decreases so significantly, and then you just have some fractures that occur. Sometimes, most of the time in these cases, you just let them heal. They do have surgical procedures for those types of fractures that are kind of, you end up with mixed results with them. But oftentimes we try to let them heal and rehabilitate instead of actually intervening surgically. So hopefully that is something that you guys, that helps everybody understand a little bit of what's going on whenever their orthopedic surgeon or neurologic surgeon points out all these different things in their MRI. Remember, the big thing is it's rare, unless it says something like, tumor. It's rare that any of these things set off significant alarm bells. The powerful, these information really becomes powerful when it's combined with your symptoms. So if you have a disc herniation and you don't have any symptoms really except some low back pain and maybe a little bit of tingling in the foot, then we're going to be conservative with that and try to rehabilitate it. And I have rehabilitated plenty of people with disc herniations to a point where they have no issues. Then, however, if you have a disc herniation and you have numbness and tingling all the way up and down the leg, you have weakness that's actually getting worse, or you have bowel and bladder issues that have changed recently with that herniation, that's a case where we need to get you into a surgery pretty quickly, most likely. But there's a lot of room in between those things. So the key is that things are not improving. So when we're looking at early management of low back pain, the next section down here, we need to consider things. We need to consider first that this can prevent chronicity. We need to also consider when and why to send someone to get some imaging, because as a physical therapist, you can see us as physical therapists right off the street. You don't need to go see anybody else. You can come straight to us and we can initiate treatment. So in that, we can start treatment more quickly. We can get into that active phase of treatment right away. And that's been shown within those first 2 weeks. If we can get someone in, we have a significant improvement in our potential for healing versus waiting, a month, 2 months to get in. That decreases our potential to prevent chronic symptoms. But with that, we have to be able to identify when we send someone for imaging. So there's some specific rules that we can follow, but generally, if it's a significant traumatic mechanism of injury, we would want to rule out fracture. Then after some time, if we're treating them and the neurologic symptoms are getting progressively worse. So they start out with some weakness in their calf and maybe a little bit of numbness. We treat them for a week or so, and it went from that to severe weakness in the calf, drop foot, a bunch of other factors. Then we would say, okay, no, it's time now to refer on for further orthopedic diagnostic workup. Another thing is, if we treat them for a while, for 2 or 3 weeks with conservative care, and they have no change in symptoms, that's something we would expect, at least a mild change in symptoms in those first 2 weeks, really the first week. So those are things that we need to be aware of. And then if we identify someone, or if you're kind of self-managing initially, and your pain is so severe that you really can't function, you can't get throughout your day, you can't stand up, then you just need, using some sort of pharmacological management will be helpful. So in that case, maybe taking some anti-inflammatories, like non-steroidal anti-inflammatories like ibuprofen or naproxen, or going one step further and calling your primary care practitioner, or going to a MedExpress and considering getting an oral dose pack of steroids. That's a little more aggressive. We want to limit how often people use steroids, but that's something that could be potentially beneficial for calming down that initial course of symptoms if they are in fact severe. Otherwise, if they're not super severe, you need to let the body heal over time. Initially, the initial few days, it's good to try to be relaxed. Don't overstress the system, let it heal. And then after 3 or 4 days, you could start to get moving again, see how your body tolerates that movement. But again, I would not let this go for longer than 14 days without an assessment, because if we do, our chances of improving it significantly decrease. Not that we can't improve it, it just means that it's going to be a little bit of a longer course of care and more effort on your part. So obviously I'm a little biased towards physical therapy, but especially with these acute cases of low back pain, it's hard to find a more effective treatment technique in the medical realm than the techniques that we can utilize in physical therapy. So this is something that physical therapists can really hang their hats on and really truly help people get better and help a lot of people get better. Because if we can stop this acute pain early, then it won't turn into chronic pain. And then the low back pain epidemic will be much different years from now if we can get word out about our ability to treat this stuff. However, sometimes it does happen, even if with the right treatment, that pain can become chronic in the low back. So if we go back up and look at that terminology, our imaging terminology that we started with, that stuff's important, especially in the case of acute low back pain. Once we get to chronic back pain, the symptoms are much more important. The symptoms really trump the imaging findings. The imaging findings at that point are just kind of, yes, I mean, you do have some stenosis, you do have a disc bulge, you do have this and that, but the symptoms kind of take on their own presentation oftentimes. And what I mean by that is, and this is probably a big reason why back surgery is such an unsuccessful endeavor. You know, usually people say 50-50 as far as success rates post-operatively with back surgery. Now that depends on the type of surgery for sure. So, however, the thing about back surgery is that it treats anatomy. So, but if your pain lingers around and to a point where it becomes chronic, it's not just your anatomy that's causing the pain. It's your whole system that's upregulated from a fear of moving this area that it perceives as injured. So any information it gets from the low back, the brain, any information in the low back, the back gets from the, sorry, let me restart that. Any information that the brain gets from the low back, it will perceive as danger and send pain signals back down to the back. So that's where the symptoms really come into play. We need to try to calm down those pain signals. And then once those pain signals are calmed down, then we might be able to consider the imaging again to help calm things down from an anatomic point of view. But until we can do that, it almost doesn't matter what we do from an anatomical point of view. Oftentimes these people still have persisting pain. And that's what makes treating low back pain so tricky. And that's why we've been so grossly unsuccessful in managing it over the last number of years because of our lack of respect for the other systems at play other than just the anatomy of the back. So these are important things to keep in mind. And there's some other risks. What are the risk factors? Like, why do so many people end up with chronic low back pain? Risk factors are obesity, smoking, high initial pain level, depression, difficult working position, carrying loads. Sedentary lifestyles are another big factor here. So you can see, I mean, a perfect example of what I was talking about earlier is that depression is a significant risk factor for causing chronic low back pain. And so if somebody is depressed, that doesn't have anything to do with their low back pain anatomy. It has to do with their ability to participate in their daily life and you know, be successful with it. So that's more a big factor in that chronicity of low back pain. So these are factors that we have to respect and understand when we're treating these patients. And that's kind of that historically poor management principle discussion. So I had that before we got to that bullet right there. So that's kind of what I was referring to, just the idea that historically we have not treated it very well. Now, when we talk about risk factors, it's always important to identify things that are modifiable versus non-modifiable. So things that we can change versus things that we can't change. So From this list of risk factors up here, things we can change would be obesity, smoking. Can't really change the pain level initially. It is what it is until we can intervene. So that means like that initial onset of low back pain, how bad is it? And if it's really bad, that's going to increase your potential for chronic symptoms. Working positions, sometimes we can change that, sometimes we can't. And in carrying heavy loads, we can change that in some certain ways. But really, when I look at that risk factor, I have a lot more questions than answers from it, right? So same with the difficult working positions one. But when we refer to carrying heavy loads, one thing that we know about the body, and if you've listened to me talk before, you probably know that I'm passionate about these ideas of loading our body and expecting a response from our body in a certain direction. So if we load it slowly, building it over time appropriately, our bodies are capable of some pretty amazing things. Now, there is a breaking point that occurs, right? For runners, if you're running 150 miles a week for 17 years, you're going to end up with arthritis in your joints. Like, that's going to happen. But if you are also sitting on the couch all the time and not moving at all, you're going to end up with arthritis in your joints. That's going to happen. So if the key is an appropriate amount of activity, an appropriate amount of movement. So if we're talking about carrying heavy loads, how are these people carrying the heavy loads? What kind of strength training are they doing to help them be able to carry these heavy loads and adapt to carrying these heavy loads? So it's not just, it's so simple. Same with working positions. Like, yes, like to me, sitting is a difficult working position. What does that even mean? And I don't have the details on it, but just want to kind of go into some detail on questioning some of these things, because there's a lot of factors at play in these cases. So when we move down to the passive versus active treatments, and I'm referring mostly to the physical therapy realm here as far as these treatments go. When we talk about passive treatments, we're talking about massage, joint mobilization, electrical stimulation, traction, ultrasound, all these things that you have done to you, right, as a patient, versus active treatments are things that you do to yourself. So when we look at chronic low back pain, we're much more successful with, you guys are going to hate this, the active treatments than the passive treatments. And the reason there is because we've got to get these tissues tolerating movement again. We've got to get that conversation between the brain and the back improved. And we've got to basically show the brain that the back can move and tolerate movement, and then gain movement and gain strength and support and fortify this back with strong tissues. Passive treatments are nice for short-term pain relief, and I use them all the time in my practice. But they're not as effective in chronic low back pain as they are in acute low back pain, where they can be very powerful and help people get out of that kind of painful cascade that's happening. And I'm not saying that I don't use these treatments in chronic low back pain. I absolutely do. But we've got to understand what the true goal is. And if the true goal is to help people move better, then we have to get them to move. We can't just lay them on a table and throw some heat and stim on them and say, this is going to help you be better. It'll make you feel better in the moment, but physical therapy, physical therapy is not like a spa. You could go to a spa and get these things too, and you will feel better. But we've got to take an active approach to this, if we're actually going to get people moving better and becoming more active in their lives. Moving on here from chronic low back pain to discuss surgical management. I'm not going to go into extreme detail here because I'm not a surgeon, so I don't want to say anything that is completely incorrect. But if we generally, I think any surgeon would agree that we have historically poor outcomes with respect to spine surgeries. And I did say earlier that depends on the specific surgery that's been done. There's some surgeries like microdiscectomies where they basically go in and shave off the part of the disc that's herniated or bulging out. And they can be pretty successful if the right patient is selected. And that's the hope with these community outreach programs like this, kind of discussing other things that you can do with low back pain. The hope is that we can help surgeons end up with more appropriate patients in their clinics. Because right now, especially around this area, what I see is people identifying like the orthopedic surgeon as their entry point into the care continuum for orthopedic issues. Because orthopedic surgeons are extremely highly trained and extremely skilled, but they do surgery, and there's all kinds of things you should do leading up to surgery. Using an orthopedic surgeon as your entry point is going to result in more people getting surgeries because they are being seen by that surgeon right away. Now, most surgeons are very diligent about their selection of patients that they will use. They have a specific selection criteria, and they oftentimes refer to physiatrists for different types of injections. A lot of orthopedic surgeons do injections. They often refer to physical therapy to try that first. So a lot of them are very diligent with that. But if the patients, just by going to an orthopedic surgeon at first, they're automatically equating surgery with fixing their issue, which is just simply not the case. So we've got to help people understand that there are a lot of other ways to fix their issue. Because again, if we go back to what I've been discussing, anatomy is not the whole issue. Anatomy is part of the issue, but there's a bigger picture of what's going on. So even if you have some findings, all these findings that are scary findings in the low back, that doesn't mean that you're doomed to have pain for the rest of your life. You're doomed to have pain for the rest of your life if you don't intervene early and have a successful course of care early in your treatment. So doing nothing in the cases of low back pain initially is okay for the first week. And after that point, it's something you should probably consider having somebody intervene with. So all this to say that the hope is, as more people understand there are other options before going to a surgeon, hopefully the surgeons will end up with more appropriate cases in their office, and then they can spend more time doing surgery than triaging patients, because really that's what surgeons want to do. And I don't, they trained hard to do it. So that hopefully will help the whole medical care continuum improve its efficiency. Exercise principles, just things to understand. So I've talked about this stuff in the past, but just a quick review. If we consider things like the key to understanding exercise is that we stress things to make them healthier. If we stress things too much, too fast, we end up breaking them down. If we stress them slowly and just right, then we end up building them up. The example that everybody can see and feel with that would be a callus versus a blister. On our skin, if we overstress our skin too much, too fast, we get a blister, our skin tears. But if we stress it slowly over time, that skin thickens and becomes healthier, and we can use it to do much more throughout our day. So those same principles occur in our tissues, our bones, our muscles, our tendons, our ligaments. Everything responds well to stress, as long as it's given at an appropriate dosage. And it's all about dosage in these cases. Like I talked about running earlier, overdosing on running or underdosing on running can lead to more significant arthritic changes than the right dosage of running. But you don't have to run. That's just an example. Something else to consider is our joints and discs. So a lot of our body is fueled by oxygen and nutrient supply to tissues. Those tissues would die without oxygen and nutrient supply. Most oftentimes, blood flow brings that oxygen and nutrient supply. However, intervertebral discs and joints, cartilage, don't have a very good natural blood supply. The way they get nutrients and oxygen is through movement. So when we move, we create a suction effect in the joint or in the disc space, and fluid gets sucked in with nutrients and then it gets pushed out, sucked in and pushed out as we move throughout our day. So if we don't move, then our joints and discs become less healthy. That's just how it happens. So doing nothing, again, is just as bad as doing way too much. And then some principles to understand: as the body responds in a favorable way to that slow amount of work that we put on it, we can progress it almost to a point with some people where there's almost no ceiling. I mean, it's amazing what the human body can do. But we can progress up to a point where you're tolerating the things you want to be able to do, and you're doing them well throughout your daily life. Then we can build movement tolerance and movement quality. So the movements that you want to be able to do. So if you're someone that has to carry heavy objects, heavy loads at work, then we'll work you up to that point where you can tolerate carrying heavy loads if your spine allows it and it seems appropriate for you at the time. Those are discussions that we have on an individual basis, but we've got to make sure we're being active with our approach and helping people progressively build up to become better each day they come in here. Okay. That's all I have. What questions are out there? Let's see if the chat has anything. For some reason, I'm having trouble reading things on my computer here.
Right at the moment, I don't see anything in the chat, but anybody who would like to ask a question is welcome to, or if they'd prefer, they can obviously unmute and ask the question. I wanted to ask, because you had talked about people coming to an appropriate level of activity, not overdoing it or underdoing it in terms of what leads to arthritis and stress. Who are the best medical professionals to discuss that with? Would a physical therapist be the best person, or should it be, a group of people you discuss it with to kind of come to an understanding of that for your own body?
Right. So I think a physical therapist is uniquely situated, like with one foot in the medical realm and one foot in the fitness realm, to have those discussions pretty effectively. That said, I think certain primary care practitioners that have a good understanding of exercise would give you the same response, and certain personal trainers that have a good understanding of medicine could also give you a good response there. But to be honest, I mean, again, I try not to let my bias shine through too much. But with physical therapists, I think we're just well equipped to answer those questions more than many other medical practitioners.
Okay, thank you. Do we have any questions for anybody else? Anything anyone would like to ask?
And with that, just coming to physical therapy doesn't automatically mean that you go through an entire course of care, right? So coming to physical therapy, we could just have one visit and discuss those issues, and then kind of set you off on your own. It really depends on the motivation of the individual and the goals of the individual.
Okay, well, thank you very much for coming today. I appreciate it as always. It's always great to hear from you. We have an event coming up next month, same time. It's going to be March the 28th at 2 p.m. I'm going to put a link to the Facebook event in the chat right now. I will also put my email address in there in case anybody has any questions for me afterwards. And I think will the handout for this session be available, Dr. Gundling?
Yes, I can send it to you.
Okay, then yeah, if you are interested in receiving a copy of that, just send me an email at littlec2@einetwork.net, and I will get a copy of that to you.
All right.
Okay. Well, thank you for your time, and I very much appreciate it as always. And yeah, we will see you soon.
All right, sounds good. Have a great day. Thanks for tuning in, everyone.
Bye.
See ya.